So we have seen general outline about arrhythmias. We already classified them. We have seen various treatments. Let us go quickly for both treatment. Actually, I am presenting slide from official slide which is given by AHA and ACC, that is American Heart Association and American College of Cardiology slide. And let us go first for the atrial fibrillation or flutter treatment, and then immediately quickly we'll go for ventricular arrhythmias. So how these are based, these details are there. Then what are the people who are involved in that? So these are various levels and various class of drug, that is class of recommendation. We have seen it many times: class 1, class 2, class 3, and level A, level B, level C. So these levels will be always been there. These are very fixed one now for the treatment, and the best treatment is level A, and class 1 is the best treatment. It is always first line treatment. Now, what are the various comorbid chronic conditions along with these atrial fibrillations? So it can be hypertension, then ischemic heart diseases, hyperlipidemia, etc. So these are various conditions, and those which are having age, which we have made the difference, that is either beneficiaries that are having age more than 65 years or age less than 65 years. So you can see number of cases comparatively are more in age more than 65 years, and comparatively lesser in age less than 65 years. And in that, what are comorbid diseases? They are almost same in both conditions. These are the comorbid conditions which has to be kept in mind. What are various definition of this atrial fibrillation? Paroxysmal, persistent, long-standing, permanent, and non-valvular. These are various situations. So paroxysmal means that terminates spontaneously or with or without intervention within 7 days of onset, and if that episode may recur with variable frequency, that is, we call it as a paroxysmal. That terminates spontaneously means without this, it was there earlier, fibrillation was there, and now there is no fibrillation. Okay, so it can happen with spontaneously or any treatment within 7 days. So this is a paroxysmal. Persistence means which is continuous, which is sustained greater than 7 days. Long-standing persistent means continuous for more than 12 months. Permanent means it is used, patient and clinician make a joint decision to stop further attempt to restore and normal maintain sinus rhythm. That means it is not coming in control, and either it is not harming, and in that cases the doctor and patient think that there is no point in going for bringing doubt whatsoever level it has maintained with whatsoever treatment or whatsoever it should be continued. So this is what permanent. Acceptance of atrial fibrillation that represent the therapeutic attitude of the part of the patient and clinician, and that is rather than inherent pathophysiological attribute. So these are the condition. And non-valvular means there is no involvement of wall in absence of any rheumatic or mitral stenosis or mechanical or heart wall or mitral wall repair. No wall related activity is there. These are the conditions which are there. So these are atrial tachycardias. These are various atrial tachycardias. We can see this. These are because of the presence of various bundle block. It can be atrial tachycardia, atrial flutter, atrial fibrillation, like that. These are, you can see the changes. Constant regular P wave flutter, morphology and rate typically is more than greater than 250 beats per minute. Mechanism is macro entry, that is this is how entry is there around it, circulatory entry. Then focal focus means, I told you there is ectopic focus or there is some focus is there, an additional point apart from SA node is there. So there is a discrete P wave. You can see the changes in P wave with isoelectric segments are there. Similar segment is there mechanism is again here also it can be because of macro entry or automaticity. Automaticity must be, you must be knowing SC node has got automaticity, AV node has got automaticity. So these are all automaticity. Diagrams that some then what we are going for that, the cardio tricuspid isthmus dependent. So it is at the right atrial re-entry dependent on the conduction through this cavo-tricuspid isthmus. This is the anatomical segment which is surrounding SA node, and it can be cured by ablation. Ablation means surgical removal of that. It may be catheter, it may be burning, it may be, there are various ablation treatment. That much portion is removed, that is called as a surgical ablation, and this can be removed. This is one of the treatment. If it is a non cavo-tricuspid isthmus dependent, it is not related to that, then in that condition what we shall be doing is, the circuit is usually defined by atrial scars, and for that these treatments can be surgery, ablation, or if it is idiopathic, then what can it be. The location will be determine ablation approach and the risk. The multiple re-entry mechanisms can be present into that. If it is right atrial, then re-entry around the healed surgical incision in the pre-wall of the right atrium. Now what is injury? Because we have seen that when say ablation, then that much portion is removed, so there is a injury, and around that it can be moving. Left atrial means there is a perimetral flutter, left atrial roof dependent flutter, others are there. Then counterclockwise atrial flutter or clockwise atrial flutter, as per that there will be cycling, there will be movement against it. So these are various ways by which we can we can have the pathophysiology of it. Now what are various things which are responsible? It can be extracardiac factor like hypertension, obesity, sleep apnea, hyperthyroidism, alcohol, drug, like that. They will affect the atrial structures, they will cause abnormalities like fibration, dilatation, ischemia, infiltration, hypertrophy, etc. That will lead to this atrial flutter or atrial fibrillation. These all are causing atrial this tachycardia and remodeling, various factors. Then there are factors like genetic variants, that is channelopathy, cardiomyopathy. Channelopathy means we have seen that we have got channels into heart. Gap junctions are there and they are making channels, so they are affecting the structural abnormality. There are some inflammation or oxidative stress because of either drug induced, chemical induced. Then renin angiotensin aldosterone activation is there, that can cause it. Then autonomic nervous system activation can cause to electrical. So there are two basic things which are resulting. One is structural abnormality, another are the atrial electrical abnormalities. So structural are fibrosis, dilatation, ischemia, infiltration, hypertrophy, and the electrical are atrial electrical abnormalities. There is an increase in heterogeneity, decrease in the conduction, decrease in the action potential during refractoriness. There is increase in the automaticity and abnormal intracellular calcium handling. These are reasons behind this atrial electrical abnormalities, and these are actually causative factors for atrial flutter fibrillations. Now how we are going for evaluation? So the first one is ECG documentation is recommended to establish diagnosis. What is the this course of action, that is okay, that is recommendation, class of recommendation is 1 and level of evidence is C, class of recommend, okay. Then prevention of thromboembolism, I told you in earlier class that the problem is bigger atria, the arrhythmias with the atrial, that is atrial fibrillation flutter, at such they don't have big role or big impact on cardiovascular performance, because spinal pumping is done by ventricles. But the biggest problem is because of the auricles, and this auricle can cause there is stagnation of blood, and this stagnation of blood can result into passage of clot into various organs, and that can be very dangerous. Patient may die with it. So always whenever there is atrial fibrillation is there or flutter is there, in that cases we have to go for thromboembolism prevention. How we are going for? So in all cases the class of recommendation is 1, that is always the first line, it is always acceptable. So in patient with atrial fibrillation, antithrombotic therapy should be individualized based on shared decision making after decision absolute risk and what are the chances of stroke and bleeding and patient's values and preferences. So these are all things are done accordingly. It is always recommended to have antithrombic treatment. Selection of antithrombic therapy should be based on the risk of thromboembolism irrespective of whether AF pattern is paroxysmal, persistent or permanent. In any case, whatsoever there is atrial fibrillation, we need to give antithrombic treatment. In patient with non-valvular atrial fibrillation, there is a score, that is a CHA DS2 VASC score is recommended for assessment of stroke, and again it has got B class of level of evidences, and that is or B level of evidences, and class of recommendation is always 1. Then for patient with atrial fibrillation who have mechanical heart valves, warfarin is recommended, and the target INR intensity is 2 to 3 or 2.5 to 3.5. This is very important about INR and all. We shall study when we shall study. I think we have done anticoagulants in pharmacology. So whenever these anticoagulants are very important, and this I don't think you have this year, most probably it is in third year, I am sorry. So this INR is, we call it as a internationalized normalized ratio. International normalized ratios are based on your prothrombin time. You have done bleeding time last year, bleeding time and clotting time. On that basis prothrombin time is determined, and from this prothrombin time INRs are determined, which are the normalized ratios, and it is 2 to 3 or 2.5 to 3.5. This is the range which should be maintained. If it changes, then there are chances of blood coagulation or bleeding. So this one is the safest range in which the range has to be kept and warfarin is to be given. Then next in that is the patient with non-valvular atrial fibrillation and having prior stroke, transient ischemic attack, or the score of CHA DS2 VASC score of 2 or greater, then oral anticoagulants are recommended. Again INR we have to maintain between 2 to 3, that is you can give warfarin, we can give dabigatran, then rivaroxaban or apixaban. These last 3 are comparatively costly. Warfarin is economical, but only thing is it has to check, it has to maintain this INR, and very close observation has to be maintained. Class of recommendation wise, you will find that again these are all class 1. Warfarin is level of evidence is A, that is the best evidence warfarin is having. The other 3 are comparatively newer, so their level of evidence is less, that is B, but they are also good. Then among the patients treated with warfarin, the INR should be determined at least weekly. It is very important because it can change, I told you, otherwise there are chances of either bleeding or clotting can be there. So this is all about how anticoagulants are given and what it has to be maintained. Then this simultaneously heparin therapy can be given. Heparin is also one of the anticoagulant. So ultra fine or low molecular weight heparin they are given, and they are again having good class of recommendation, that is all are class of recommendation 1, and level of this level of evidence is C. The patient without any mechanical heart valves who require any interruption of warfarin or new anticoagulants, the decision of bridge therapy of this heparin has to be given to balance the risk of stroke and bleeding. So if warfarin has to be removed because of any ADR, then heparin has to be started, and but it should be seen that patient is always on the some anticoagulant treatment. Then renal function should evaluated before initiation of right thrombin or factor 10 inhibitors, and should be re-evaluated because it is important. Renal failure, if it is there, then you have to adjust the doses. The patient with a non-valvular AF and this score of 0, it is reasonable to omit antithrombic therapy. So we'll not go for class 2 and level class 2B and class C. These are not important. Only thing is, if the score is lesser, then there is no need, and if it has got a higher one, then warfarin is a better treatment. Then second thing is, will not go for those which are Radin and either C or B. Will not discuss about it. Only thing is, some anticoagulant along with that cropidogel or stents can be added to avoid the problem in the patients. Then these are what is the CHADS 2 and CHADS 2 DS2 VSC. So what are various scores are there? CHADS2, that is there is one C, that is congestive heart failure, one H, that is hypertension. Age is greater than 75, then will give score 1. If diabetes is there, 1. Stroke is there, then will give score 2, and maximum score that thus becomes 6. Then CHA2 DS2 VASC. So again, what it is? Congestive cardiac, hypertension, age, then diabetes, stroke, vascular disease, age 65 to 74, age category, sex category, female sex, they are having more prone, so maximum score become 9. So these are how the score sheet there. We have the, and on that basis, if the score is less, then risk is less. This is all risk factors, and if the risk is, if the score is more, that means the maximum risk is there. Above 2 is greater. Above 2 is, we can consider patient under risk category. So for that, what we have seen various drugs, we have seen warfarin we can adjust, and it has found to be very, very important, and it finds that factors, most of the things which are favoring warfarin, if you will see that we call this as a odds ratio. So this finds to be better. Then relative risk reduction is found to be good with other antiplatelet agents, but it is not as good as warfarin. And the warfarin compared with the antiplatelet, they are always found to be better in various conditions. Now we know what about various clotting, and this one will not go for this, because clotting anticoagulant pathways we shall not pay now attention. Only thing, please remember that we need to add anticoagulant treatment during that. Then we'll go for the rate control, that is how we are going to control the heart rate. So we can control the ventricular rate using beta blocker, or non-dihydropyridine calcium. Non-dihydropyridine, again, what are dihydropyridine beta blocker calcium channel blockers? Okay. So it is non-dihydropyridine is example is verapamil diltiazem, very good Chakradhar. And the antagonists, they are recommended for patient with the paroxysmal persistent or permanent atrial fibrillations. Intravenous administration of beta blocker, again, or this verapamil diltiazem is recommended. Again, class of recommendation is 1, level of evidence is good, that is B. And the other things which are there, if it is still not stable, then electrical cardioversion is indicated. I told you about electrical cardioversion, that is giving shock, or you might have seen in movies somewhere where the iron, the electrical press or iron we have कपड़े इस्त्री करने के लिए, तो उसके जैसा दो चेस्ट पे रखते हैं, that we call it as a electrical cardioversion. You can see this. Okay, so this is how this electrical cardioversion is there. Then next is the rate control can be done using symptomatic management. Intravenous amiodarone is useful, particularly where the earlier drugs are not able to control. but it is not that beneficial because it is class 2A. And the other things are there. Lenient rate control strategy may be reasonable as long as patient remain asymptomatic and LV systolic function is preserved. We can continue. Oral amiodarone may be useful for ventricular rate control when other measures are unsuccessful or contraindicated. Then we are going for this amiodarone. AV nodal ablation with permanent ventricular pacing should not be performed to improve the rate control without prior attempt to achieve the rate control with the medications. So medication should be always first line treatment, and if medications are not successful, at the end as is a very last resort to what we call as a AV nodal ablation, that is removal of some portion of AV node with surgical one or by electrical techniques, and add some permanent ventricular pacing, that is we call it as a external pacemaker. Then it is but it is a last resort, it is not the preferred one. We will not go for other this one because their class of recommendation is less, it is harmful, so it is not useful, and even level of evidence is less in that, we will not go for that. So how we are going to select the drugs for therapy for ventricular rate control? If simultaneously there is a atrial fibrillation is there. So suppose there is no other CV cardiovascular disease, then we will prefer beta blockers, diltiazem, verapamil. Again there is a hypertension or there is a heart failure having the persistent ejection fraction, that is it has not, or preserved ejection fraction. Ejection fraction has not changed much. In that case again we will use beta blocker, diltiazem, verapamil. Then there is a left ventricular dysfunction with heart failure, then beta blocker or digoxin we can use, but we will not prefer diltiazem or verapamil because they are reducing the force of contraction of heart, so we do not want it. If there is a COPD, then we can use beta blocker, particularly highly cardioselective diltiazem, verapamil, and if these are not working properly, then lastly we will have amiodarone we can add into treatment. So these are the approaches how we are selected. Most of the drugs are listed alphabetically here. The beta blocker should be instituted following the stabilization of patient with decompensated heart failure. So already heart failure is decompensated, then we can go for it. The choice of beta blocker that will depend on the patient's clinical condition. Digoxin is not usually first line treatment. Digoxin is even in actually digoxin, I told you digoxin has got a very, or in pharmacology I taught, digoxin is now it is not first line anywhere. Earlier it was first line in heart failure, but later it has been found that the other treatment like beta blocker, calcium channel blocker is comparatively better, or other treatment is better in heart failure, then digoxin is used in class C, class D type of, or stage 2 or stage 3 or stage 4, stage 3, stage 4 type of heart failure, in that it is used. Then in atrial arrhythmias also it was used earlier, but nowadays again these drugs are preferred, that is beta blocker and verapamil, diltiazem. If it is not, these are not sufficient, then we can add digoxin simultaneously. In part of because of the concern over the side effect profile, use of amiodarone for chronic control is also reserved. Who do not respond, or there is some problem with the beta blocker, then only we will go for amiodarone. Already we have discussed this, that amiodarone is not first line of treatment or first choice of treatment. Then how will control the rhythm with the atrial fibrillation? So again all our class of recommendation are one. So these are drugs, already anticoagulant we have added, and simultaneously if required cardioversion is, if there it has been done. Then taken the score like CHA2, DS2, VASC, this score has taken, and then go for the electrical or pharmacological method to restore the electrical means cardioversion. See, three methods you just remember. One is total pharmacological treatment where we are using drugs. Second is the ablation treatment, that is a surgical treatment where some of the portion of the tissue, particularly which is having more conduction or more what we can say automaticity, that portion, or which is acting as a focus, that is removed. That is called as ablation therapy, surgical, and this is done by either various surgical techniques, either thin some what we can say small wire like catheter is put into that portion, and very small knife or small what we can say motorized is there, which will be just just like your pencil is sharpened, like that some of the portion is removed from the tissue and it is sucked back. So these are the ablation, or that some portion is frozen, the very powerful, again very small portion will be there, it will go to tissue, that needle will be pricked into that and very powerful present will be there. So there will be freezing of that particular portion, and that will be dried, that will be ruptured, and that will be taken up. So these are various, either freezing, either heating, either burning, or either these are various ablation techniques. Or electrical means applying DC cardioversion, that is direct current. We know there are two types of current, AC and DC, alternating current and direct current. So give direct current and it is directly put onto chest, and this will give this current. These are used to restore sinus rhythm. The patient with atrial fibrillation or flutter more than 48 hours duration or unknown duration, if requires immediate cardioversion for hemodynamic instability, anticoagulation should be initiated as soon as possible and continued for at least 4 weeks. Why this? Because again the auricle which are had a problem, they can release the thrombus. So whenever it is done, because very powerful contraction will start after cardioversion, so in that cases immediately the treatment with anticoagulant should be done. Patient with atrial flutter less than 48 hours duration and with high risk of stroke, intravenous heparin or low molecular heparin or factor X should be direct, that is direct thrombin inhibitor, they are recommended, and particularly they are followed after the long term anticoagulation therapy. Following cardioversion of atrial fibrillation of any duration, this decision about long term anticoagulant therapy should be based on the thromboembolic risk profile of the person. So accordingly it can be given. And the next are comparatively where the class of recommendation is less and level of indication, level of evidences are also less. These are comparative, these are again related to anticoagulation or thrombolytic activities, but this can be, if earlier one are not acceptable, then we can go for this. Then next in that is direct cardioversion, when it has to be done, in what condition it is best. So I told you what is DC cardioversion. I told you about it, that it is electrical shock is applied. So it is recommended for the patient with atrial fibrillation or atrial flutter as a method to restore sinus rhythm. So what is the basic mechanism is, when it is applied, so it has got more powerful current than the AC node currents, and therefore it will be suppressing the AC node currents, and if you give it in a particular sequence, then AC node will start with having impulse in same direction, then you stop, then the sinus rhythm can be restored. Okay, just like suppose there are vehicles are going in a very abrupt manner, any vehicle is moving here or there, then all of a sudden some big vehicle is there that has been put over there, and then this vehicle is making one line, and in that line one by one other vehicles are passing. So all this chaotic situation is managed, and when this vehicle is passing, after one vehicle or along with this big vehicle the other vehicle are there, or a controlling vehicle is there. So similarly this cardioversion is a controlling potential, electric potential, along with AC node will flow, and when it is there, then the flow of impulses will be regular. If cardioversion is unsuccessful, repeated attempts at direct current cardioversion may be made after adjusting the location of the electrode. Applying pressure over the electrodes or following administration of antiarrhythmic medication simultaneously. It is recommended when rapid ventricular response to atrial fibrillation or flutter does not respond promptly to the pharmacological therapies, and it contributes to ongoing myocardial ischemia, hypotension, heart failure. Cardioversion is also recommended for the patient with AF, or that is flutter or fibrillation, and pre-excitation when the tachycardia is associated with the hemodynamic instability. So these are the conditions where it is considered. It is reasonable to perform cardioversion in patient having higher one, and various serial cardioversion strategies can be applied for that. Then pharmacological cardioversion, that is some of the drugs like which are powerful inhibitors of this voltage gate channels. We have classified them into class 1 of the antiarrhythmic drug. If you remember pharmacology, class 1 of antiarrhythmic drugs, we have made 3 classes: class 1A, class 1B, class 1C, if you remember pharmacology. So the drugs like flecainide, dofetilide, propafenone, and intravenous ibutylide, they are useful for the pharmacological cardioversion. That is, again, cardioversion means what? That is, these are causing the impulse conduction in a very proper manner, which were not properly there, and that provide contraindications to be selected drug are absent. If there is no contraindication, they are found to be better. Here the level of evidence is the highest one, that is A, and the class of recommendation is also 1, so it is most powerful. Any drug, either flecainide, dofetilide, propafenone, or intravenous ibutylide, they are most important, and this treatment are recommended actually. Then administration of oral amiodarone is reasonable, but since there are adverse effects, it is done after the above treatment. The earlier treatment was not responding properly, then we can go for amiodarone. Propafenone or flecainamide, in addition to the beta blocker or non-dihydropyridine calcium channel antagonist, these are reasonable to terminate the atrial flutter outside the hospital once this treatment has been observed to safe in monitored setting. Again, here the thing is, these are comparatively having more complications, this propafenone, flecainide, than beta blocker, calcium channel blocker. So if they has to be given outside there or for the ambulatory patients, then more care has to be taken. So here the class of recommendation is 2A, and level of evidence is B. This is particularly when the previous drugs, that is beta blocker or diltiazem, they are not working, verapamil are not found suitable, then this is the second class of drug, they are good. Dofetilide should not be initiated without out of hospital, because the risk of excessive QT prolongation that can cause torsade D points. It is again torsade D points is one other arrhythmia particularly related to ventricles. Antiarrhythmic drugs which are used for the maintenance of sinus rhythm. So these are various drugs. Example of these are amiodarone, dofetilide, then dronedarone, flecainamide, propafenone, and sotalol. These are very important drugs. Again, if you see, their class of recommendation is 1, and that is, and their level of evidence is A. That means they are the best drugs and they are the most suitable in that condition. So the treatment of precipitating reversible causes has to be done. Why? There is there, if there are medicine induced or drug induced or chemical induced, then immediately that should be removed first and then go for the treatment. The antiarrhythmic drugs which are used for the maintenance of the sinus rhythm, these are be used. Amiodarone can also be used, but again level of evidence is C and it has got adverse effects. So after the previous list fails, then we are going for amiodarone. Arrhythmia, the rhythm control strategy with pharmacological therapy can be useful in the patient with atrial fibrillation for the treatment of tachycardia induced cardiomyopathy. So there is a cardiomyopathy because of this tachycardia, in that this control of rhythm is useful. Antiarrhythmic drugs for rhythm control should not be continued when AF become permanent, including dronedarone. So again, if it is controlled, then it can be harmful. The harm can be more than the benefits. The recommendation, again, this is a harmful one, that is, it should not be used in treatment of atrial fibrillation in patient with New York Heart Association class 3 or class 4 heart failure. So in that cases, this dronedarone should not be used. Then AC inhibitor or angiotensin receptor blocker are reasonable for primary prevention of new onset of atrial fibrillation in the patient with heart failure, and there is a reduction in the left ventricular ejection fraction. So the recommendation is good one, class 2A. Therapy with AC inhibitor ARB may be considered as a primary prevention of new onset of atrial fibrillation in the setting of hypertension. Statins can also be used if there is any lipid related problems are there. And therapy of AC inhibitor ARB or statin is not beneficial for primary prevention without cardiovascular disease. So they are not beneficial, much beneficial if there is no cardiovascular problem. Unnecessarily it should not be given. Catheter ablation, I told you there are various ways of ablation, that is how ablation is done. So again, it is useful in the symptomatic paroxysmal this AF refractory or intolerant to at least one class of class 1 or class 3 kind of antiarrhythmic drugs. Class 1 and class 3 now you are knowing. I will not repeat this. What are class 1? I told you again, class 1A, class 1B, class 1C, class 2, class 3, class 4, and the other class or class 5 we can say miscellaneous drugs. So these are various class we have seen as in a pharmacology. So if it is class 1 or class 3, these are the prominent class 1 and class 3 are, and if they are not working properly or they are not showing good response, then we can go for catheter ablation. Before considering this ablation, assessment of the procedural risk and outcome should be checked. Patient should be considered, patient should be informed, then go for it. If it is reasonable for some patient with symptomatic persistent AF which is refractory to or intolerant to at least one class 1 or class 3 antiarrhythmic agent, then it is recommended. Otherwise there is no this one. It may be considered for symptomatic long standing, that is persistent atrial fibrillation which is refractory to at least one drug from class 1 or class 3. So basically, if the first line of treatment is always class 1 and class 3 of the medical antiarrhythmic drugs. If it is not working properly, then we are going for other treatments. So this has to be kept in mind. Then next is what we are doing into rhythm control in the patient with paroxysmal and persistent this atrial fibrillation. We have seen structural and non-structural. There is a structural changes or there is a structure related problem. In other cases, these are electrical conductions or problem are there. So in that cases, what are our drugs? If there is no structural heart disease, there is no problem in the structure of the heart, only functioning is a problem, then our first choice are dofetilide, then dronedarone, flecainamide, propafenone, sotalol. These are important. Or then amiodarone is the next one. If still it is there at any time, either during first stage or second stage, either after amiodarone stage or after first stage, or even before that, in certain cases we can go for catheter ablation. Then next is structural heart disease. It can be the structural heart disease has been happened because of the coronary artery disease or heart failure. In that case, if it is CAD, that is, then go for this again, dofetilide, dronedarone or sotalol, and then amiodarone. If it is not working, go for catheter ablation. Now this dotted line shows, this dotted line at two places is there, that is if direct catheter ablation is there. These are in very few cases where it is felt that yes, it can be, it is okay, it can be done. In that cases only we can go for this catheter ablation. So these are the strategies which are there. It is only recommended as a first line therapy for patient with paroxysmal this atrial fibrillation, and accordingly we can think in that way. Then surgical mesh procedure, what are various surgical procedures? They are recommended again, but it has got a lesser class of recommendation and a lesser level of evidences. specific groups and atrial fibrillations. So if there is a hypertrophic cardiomyopathy, simultaneously along with this, we know what is hypertrophic. There is a growth, or we call it as a fibrous tissue development at the place of injured cells. So it is indicated in the patient with this, and the class of recommendation is 1. Antiarrhythmic medications can be useful to prevent the recurrent AF in the patient with the heart failure, and amiodarone disopromide can combine with beta blocker or calcium channel blocker, and they are useful. AF catheter can be beneficial with the patients that of this hypertrophic cardiac myopathy, and sotalol or dofetilide dronedarone can also be given in this rhythm control of hypertrophic cardiac myopathy. Then atrial fibrillation, which is complicating the acute coronary syndrome. In that, the best drugs are there. Go for the checking, and this cardioversion is recommended for the new onset of AF, particularly after ACS. Intravenous beta blockers are the recommended to slow a rapid ventricular response to atrial fibrillation in patient with ACS who do not display HF. There is no HF, but in that beta blocker these are used. For patient with ACH and AF with high CHA DS2 VSC score, that is of 2 or more, anticoagulation like warfarin should be also added. Administration of amiodarone can be considered, but this has got lesser class of recommendation. That is, we can say it is a second line treatment, and level of evidence in all cases is C. Hypothyroidism, in that cases we can control it. So beta blockers are recommended because to control ventricular rate in patient which are complicating thyrotoxicosis, unless it is contraindicated. Where beta blocker cannot be used, then go for calcium channel blockers. These are 2 drugs, and these are the most prominent. In case of pulmonary diseases, go for calcium channel blocker and then go for beta blockers if there, because beta blockers may have some this pulmonary or respiratory system effects. Then Wolff-Parkinsonism White, WPW, that is Wolff-Parkinson's White syndrome and pre-excitation syndromes. So in that cases, the cardioversion is recommended for the patient with this atrial fibrillation and rapid ventricular response who are hemodynamically compromised. Intravenous procainamide or abitulides is also recommended for such patients. Catheter ablation is also one of the additional supportive mechanism can be done for the symptomatic patients with pre-excited atrial fibrillation, especially in the accessory pathways which has short refractory period, which allows rapid antegrade conductions. Administration of intravenous amiodarone, adenosine, digoxin, or other calcium channel blockers in patient with Wolff-Parkinson syndrome, we have pre-excited AF is potentially harmful because they accelerate the ventricular rate, because here in ventricular is also accelerated, and therefore these drugs has to be used, or rather it should not be used. Heart failure, if it is there, then go for calcium channel blocker or beta blocker. Then in absence of pre-excitation, beta blocker again or non-dehydrogenase. So most prominent treatment so far you will see that these 2, that is with calcium channel blocker and beta blockers. Already we have seen it in the first slide or initial slides. Then digoxin is effective to control resting heart rate in patient with heart failure with reduced ejection fraction. So in that cases, when heart failure is also there and atrial is there, then we can plan about digoxin. It is then, but again it is after what? It is after all beta blocker, calcium channel blocker, all the treatments are not sufficient, then we are going for digoxin. Combination of digoxin and beta blocker or calcium channel blocker is reasonable to control the resting and exercise heart rate in patient with atrial fibrillation. And again, level of evidence is good, that is B, and class is 2A. So after all this, we can go for use of digoxin also if the alone beta blocker or calcium channel blocker are not giving sufficient good prognosis. In heart failure, the rapid ventricular response causing suspected or causing tachycardia induced cardiomyopathy. So it is reasonable to achieve rate control by either AV nodal blockade or a rhythm control strategy. For a patient with chronic HF who remains symptomatic from AF despite a rate control strategy, it is reasonable to use a rhythm control strategy. Oral amiodarone can also be used, that is class 2B, but that is almost we can say class or stage 3 or third choice we can say. So COR1 is the first choice, COR2A is the second choice, COR2B is a third choice, like that. So it is a third choice in that. And these things, that is ablation is not used, should not be used, it is harmful. And intravenous non-dihydropyridine, that is verapamil diltiazem, intravenous beta blocker, and this should not be administered with decompensated heart failure if it is there, because it can cause which is not compensated or that is continued. In that cases it should not be given. The patient with AF and multi-generational family members with AF, referral to tertiary care center for genetic counseling and testing may be considered, because if it is known, then accordingly planning can be done for even next generations and other people, they have a problem. Post-operative cardiac and thoracic surgery, the treating patient who develop atrial fibrillation of cardiac surgery with beta blocker is recommended, or non-dihydropyridine calcium channel blocker is recommended in the patients. Then if it is not working, then next is amiodarone as usual, or then ibutilide or other drugs. So here we complete the treatment for atrial arrhythmias, atrial fibrillation, atrial flutter,